All right. Hello. We're going to be going through some cases together, looking at some scans, and then talking about what clinically we might do in response to findings on the scan. I'm going to start out talking a little bit about anti-amyloid therapy just for a minute, as quick as I can. I realized from a radiology perspective, I think initially it was, why are we giving this high-risk treatment to these elderly patients with a cognitive impairment? That's a good question. And it in part is because it is a disease-modifying therapy and the only thing available. We can actually go to the next slide. Oh, and one more. Those are disclosures. I did do consulting one time with Eli Lilly, who produces donanemab. That's my only disclosure. I think Wendy had no disclosures. So I wanted to talk about, we're giving it to these patients because it's been shown to preserve function for at least a little bit of time when we don't really have anything else available. And if we are careful in monitoring, typically it's pretty safe for patients. And I would say in my clinical experience as well, there has been very limited severe ARIA that I've been exposed to personally. So when we're trying to think about who should go on this treatment, it's actually a really restricted population, really restricted. It's for people who are mild. They should have decision-making capacity in some regard. So they are involved in the treatment to go on the medication. They could be driving. They could be working. They could have just retired. They could not be driving and need some help, but they're really independent for the most part. Additionally, these people need to have been worked up for Alzheimer's disease and have a biological diagnosis using biomarkers. Right now, amyloid PET or spinal fluid. In the future, I think we'll be using serum testing, which has become more reliable. And then there's some restrictions. We know about ARIA. You guys, I'm sure, know about ARIA. We know that patients on anticoagulation are at a higher risk of having a symptomatic hemorrhage. And so we, at my institution, don't give it to people on blood thinners. And according to the appropriate use criteria, it is also recommended to not give this to patients on blood thinners. However, I know neurologists at many institutions who are giving it to patients on blood thinners, as that's what was done in the trial. And it is not contraindicated according to the package label. So just to prepare you, each institution may have different restrictions on who's receiving this treatment. We also were not giving it to ApoE for homozygotes because of the increased risk of symptomatic ARIA. I know institutions in the Chicago area who do give it to ApoE for homozygotes, and we are about to start doing that because there's a new titration available for donanemab that has been shown to decrease that risk. So this is an evolving field, to summarize. Lastly, there has to be an MRI in the last year without these exclusionary criteria. This is the importance of the baseline MRI scan, to exclude patients who aren't eligible and to have a baseline count of things like microhemorrhages, lacunar infarcts, superficial siderosis, so that on their next scan, we can compare and know whether or not it's related to the treatment. We're going to talk about vascular malformations a little bit at the end because there's some questions specifically around the venous side. Patients who have significant white matter disease in their brain, who have a significant cardiovascular history and are likely to have a stroke or a heart attack because they've had one previously in the last few years, or have a very strong family history, we will talk to patients about what could happen if they need to receive a blood thinner, if they need clot-busting medication for a stroke, which they're not supposed to receive now that they're on this treatment. So we exclude a lot of those patients based on their risk factors alone.
First, can I ask a question? So I'm super excited that we're doing this because radiology and neurology, believe it or not, we don't talk much at most places. I think there is so much separation between the specialties. They're so siloed, more than anybody would believe. So I'm learning here. I'm super excited because I already have so many questions because we have no way to find this out. So radiologists. Yeah. I mean, you just taught me a couple of things here on this slide. So this is how we find out because you said like it's evolving, but we aren't even caught up with the first wave of it. Yes. So I think I was first year attending when the first ARIA drugs came out, and then we were quickly discontinued because of complications. Yeah. So when they came back, I'm like, wait, what's happening? What changed?
Yeah.
And nobody could tell me.
Yes.
Like,
and
no.
and I I actually have some people who I trained with in residency who practice at what are considered community hospitals a little further outside the city. And they just weren't offering it for a period of time because they felt like they couldn't safely monitor. It wasn't really clear. Why are these approved when those other ones were taken off the market? I'm not going to explain that fully here because it takes too long, but there was a reason. And these have consistently been shown some benefit, which in this risk-benefit discussion, some patients think outweigh the risks. But it is a very in-depth discussion we're having because the symptoms of ARIA can be life-threatening and can land someone in an ICU with permanent neurological deficits or can be completely asymptomatic. The most common presentations are dizziness, falls, confusion. That's most patients at baseline have little days when they're not doing as well. And so I know as radiologists how important it is when we write in the comments what the symptoms are so you can localize and know where to look. And it is going to be challenging because there are these diffuse type symptoms that don't really correspond to a specific place, which I think is why a standardized program or way of monitoring for these is really important.
Yeah, that's just a comment. This is probably skipping ahead a little bit, but I think in this session, we're not just going through this, but we're also talking about real world problems because that's what everybody's facing out there. And I was telling these guys that, so our EMR, which is not the one that's fancy. So the only way we cannot create a workflow, an order set. So when the neurologist orders it, the only way we're going to know it's an ARIA study is if they write in the little notes section.
Right.
And so the tech sees that. So the tech has to know. And so if they don't have that, then we don't know it's ARIA. We don't read it as ARIA. There's no template that comes up the way we have it now. So you're right. That's why this is super valuable. And having these pathways is really going to, I think, help everybody. It's going to help the patients and you and mostly us, I think. So one question about the exclusion criteria. Wait, go back. I heard that aneurysm was on there too, no?
It is. I counted that in the vascular malformation world. AVMs, aneurysms, a history of ruptured aneurysm. I actually think there's a specific size measurement for size of allowable aneurysm. It's usually like the size of ? Infundibulum, is my awareness. But history of hemorrhage inside the skull is concerning to me for someone to be receiving this type of treatment. This shows how we decide what to do. So because these were studied in depth in trials, there's a very procedural approach to how we manage patients on these treatments. And it's mostly in response to the read we get and the size of any ARIA lesions and how many there are, because that corresponds to a certain level of severity that we then match up with their symptom severity, which is quite subjective and subjective to the patient and subjective to the physician. And we need both of those things to know if the patient especially can restart therapy if it's been suspended for a period of time, but also if we can just continue it without suspending it. This is the kind of pathway that we use. And you can see there's a little difference between symptomatic and asymptomatic, where if someone is asymptomatic and only has mild ARIA, they can continue treatment with closer monitoring. As opposed to anyone who has any symptoms, they automatically are getting treatment suspension and then determining whether or not they resume treatment based on resolution of lesions, stabilization of hemorrhages. There's another graph or another chart that I don't know if it's on a different slide or in here, but it has the actual grading recommendations for superficial siderosis, microhemorrhages, ARIA-E. And that's kind of the most essential piece that I'm looking for as a neurologist to then determine what am I going to tell the patient we're going to do next.
Yes, the grading system. That is my thing, is grading systems. But again, if you're in a place that doesn't have already automated, like the orders go in and bring up the templates automatically, if you don't know to use the grading system, a lot of people don't know the grading system now. So if you have it built in somehow, it's super helpful so you don't have to look it up, right?
And I actually got an urgent page that my patient had press They didn't. They didn't. They had bilateral parietal of ARIA, and it's, they had to go to the ER anyway, and it's not managed super differently. But it's important that the radiologist knows the clinical situation. I think we're trying to incorporate it into the order. I think there's a lot of different ways of doing it, but having an automated system definitely is straightforward.
Okay. All right. So let's talk about this case. So 74-year-old, I lost 2 words there, with memory difficulties. Okay. So when this person got their MRI, which is going to become their baseline when we decide that they're a candidate for, or if they are a candidate for anti-amyloid treatments. So this, every radiologist here gets more sequences than this, but this is the bare minimum we really need. And I think everybody's protocols has these 3. So the first one is a 3D flare. The second one is our gradient echo. And the third one is just our regular T1 for morphologic assessment. So a lot of people now get SWI. That's another topic we'll talk about at the end if we have time. But usually everybody has SWI or a gradient. And now that we are knowing we have to look on gradient, or some of us believe that because of the trials, we are adding gradient echo back, but that's another story. Okay, so we have this. This is our person. Goes to Dr. Lapins, said, yes, we think you have early Alzheimer's, so we want to put you on treatment. Are you eligible? So when I go through these, so when I was in residency, the way I was taught is on mammography. That was the best example at that time. So we were taught, first look at the study yourself and see what you think, and then use the CAD to identify anything, like look at that next. And then that points out what we should go back and look at. So it's kind of, I do it this way too. I don't know if everybody does, but so I'm kind of looking at that, or my fellows are looking, one of my 10 fellows, each one of them would probably say that's a different amount of atrophy or volume loss, every single one of them. So this in itself is a big thing, because we kind of have super subjective. We kind of have a general idea of what we're going to say, and maybe we know severe from mild, but at the same time, you ask anybody out there what they think of that, they're going to say different things, which is why having real volume, I think, is super helpful. Everybody here knows, well, not everybody, that I'm a skeptic. I'm a late adopter. So for me to say this is helpful is actually a huge deal. I think it's super important. So I would not say that unless I really thought that. So anyway, this person has global volume loss, and they also, not in this image, have hippocampal volume loss. I shouldn't say it's left. It's lower limits of maybe normal for age. Now, that's another debate, like what is normal for age, but we're going to go with what's always consistent, standardized, because again, radiologists will tell you different things, but this is going to tell you the same thing. So we talk about, this is super helpful. I was going to say, we don't talk about separately parietal and temporal and unfrontal occipital, but that's pretty helpful to you.
Yes.
For assessment of what kind of dementia it is.
Really important for assessment. Well, definitely differentiating between Alzheimer's and FTD. Lewy body, I think maybe there's a question mark of some specifically like non-specific atrophy involving also the occipital lobe, but I don't want to go on the record saying that. I just did. Okay. But this pattern, sometimes the atrophy is not obvious, especially in my young patients who are coming in with early symptoms. Those are the most treatment motivated patients. Knowing whether or not for their age there is any amount of atrophy is really helpful. And then seeing, is it in this pattern that we tend to see in amnestic Alzheimer's disease, hippocampal, parietal, temporal, memory, awareness, then we can kind of say, based on their MRI scan, that the pattern is looking like Alzheimer's disease, which is kind of harder for us to say, just looking at the scan clinically, me as a neurologist, not a radiologist.
Yeah, so that's, I think you'll find most radiologists probably shouldn't be making that determination either, right? So that's, so like I said, I'm going to make myself sound really bad here, but this is true. And I think it's like the real world out there. It's like so many practices. This is neuroradiology at a pretty big place. You think about all the community places like you're talking, I think I'm in the same boat, so please forgive me if I sound bad here, but we don't talk about all those things. We didn't know they were important, but now we do. So now we're going to start talking about them, right? And also, so this is super helpful for me too. So I never used to think that, but now I do. So I look automatically. I like the 6 first to see where the patient is in these different areas compared to their age-matched controls. But before, I didn't know what that circle thing was. I'd never seen that before, but now that I know the patterns, that's like best. It's like I can see that little house pattern of Alzheimer's, right?
Yes.
That's like, so you have more hippocampal, parietal, and temporal volume loss. It's going out toward the more severe, yeah?
Yes. When it goes further out towards the periphery of the circle, that's where there's atrophy in that lobe. And so if it was normal, it would all be in the green, I believe. And then as the top of the house goes up, the hippocampi are shrinking, and then parietal and temporal lobes. And it's not always this pattern, but this is kind of the typical amnestic pattern. And then there are atypical presentations with lateralization of the atrophy. And if we have time, we may talk about that at the end.
I have too many questions. Sorry. No, but again, this is for radiologists. I don't know. So this thing is super helpful. I've been convinced before. I thought, what is that thing? But now I see how easy that is. And so when where I am, we have like on our MRI rotation where we read these, we have like 80 a day in our 8-hour shift. And I don't have more than a few minutes, and I don't have time to be analyzing it and so in depth. So if I have that, that's super helpful, even if it's to confirm. Yes, I'll say to confirm. Yes. So, okay, so let's go on unless there's anything else to say about that slide. Okay. So now, so we're looking for the eligibility criteria. So you heard we're looking for microhemorrhages and superficial siderosis. We're looking at the white matter, or the microvascular ischemic changes. That's another thing that I actually used to talk about when I made my standard templates as physicus, but nobody talks about that anymore. So I don't know how many people that are radiologists know that, but we need to know it and we need to talk about it. Now I'm justified. We talk about the lacunar infarcts and the vascular malformations, like you mentioned. So this patient, the first one is it's that 3D flare. It's like 3D cube flare. And then the second one is our gradient echo. So this is our baseline. And you see there's so the physicus for the, deep white matter, I guess, is most important. So you have like some early confluence. You have patchy early confluence. That's physicus 2. And then on the gradient, we don't have any microhemorrhages on that slice. So, and none of the other things. So good to go.
They're good to go.
Good to go.
They're eligible.
Oh, and this confirms it. So I know I didn't miss something. Oh, and it gives us volume. Sorry, which is super helpful because, again, super subjective. And if we have that to track, I might not notice like a 10%. Well, I would notice. I wouldn't notice a 10% change, but this would help me and my fellows, mostly me. Okay, sorry, Lars, go on. All right. And so also this has been huge lately, the structured report that goes with it, because just at one of our recent meetings, actually a couple of them, people like radiologists were finding out that the structured report actually is automatically produced. And everybody who's heard about like a lot of stuff before, like, oh, whatever. But then they hear this and they're like, oh, wow. This sounds like, or looks like a lot of information, but this is what you need. It's taken from the analysis, put into your Power Scribe, right? Whatever, your report.
Yes, they started treatment. They began treatment and they're getting their first post-treatment study, let's say a month in. We're on lecanemab.
Okay. So in these two, so our first two are the flare images, and they look different because the first one's a 3D cube flare, but the second one is just a regular 2D flare. So sorry, they look different. They are both flares. That 3D is a good one to start beforehand because that highlights white matter hyperintensity more. And so if we don't see it there, we know it wasn't there, right? And so on the second one, can you point, Lars, to, we see some new, can you see from back there? You have new hyperintensity in the sulci and the occipital. So so that's something new. So this is RAE. So that's a sulcal effusion, RAE. So now something has changed. Our gradient, that was the baseline. This is that 1 month follow-up. No new microhemorrhages, no siderosis. So no RAH. They do have RAE. So now,
so they've got a little area of ARIA-E. And what I'm looking for in the report is it mild, moderate, or severe? Because that is determined on the measurement that you guys are going to provide, as we cannot be relied upon to measure the longest diameter reliably as neurologists. You guys probably are aware of that.
No, so that's something, again, I think when we started getting these, which wasn't that long ago, we didn't know we had to measure it.
Right.
And we don't know how to measure it. And if you have 5 different, I'll say fellows, but whoever, measuring that, they're going to measure that differently. So that helps to have it both highlighted, so you know where it is, and measured. That's great. And again, for consistent follow-up, it's always going to measure it the same way, so that helps us track it. Also, if we only have one site of involvement, right now we've only got mild, RAE, and I don't want to look up the severity table, so that helps me remember. Oh, yes, that's mild.
Yeah. So if this is, mild, and let's say this patient has probably no symptoms from that, realistically, it's pretty small. Maybe they'll have some visual changes. I might talk to the patient about continuing their treatment and getting more frequent MRI scans to monitor them and having them really monitor themselves and maybe telling a family member to monitor them for any symptom development, as the patients sometimes forget that they developed symptoms. So we continued treatment and we got our next MRI. Oh, sorry. There was no ARIA-H on the initial, on that scan.
Can you actually go back for a second? This is another thing that just, again, it's going to be in the community, because I think a picture like that, you were talking about your patient with press.
Yeah.
So when we see something like that, that's kind of unusual, these sulcal effusions. And before we knew about ARIA, we never would have, we didn't know to call it ARIA. We would have said, does this person have an infection? What's going on? Or is it a weird artifact? I don't think so. It looks real. So for the people out there that don't know about it yet, that is super, super helpful. And again, this is neuroradiologists, you don't know it. People in general have to know everything, every body part, every modality. You can't keep up with everything. So having some little clue.
And at my own institution, I can communicate via the order or by phone or by page. This patient's coming in for the scan. They're symptomatic. We're looking for this. My patient can take their MRI order anywhere in the country. They could be traveling and develop symptoms and need to get an urgent MRI scan at a random emergency room. I can't see that scan. No one at my institution can see that scan. We're relying on this community radiologist at a random hospital to know what ARIA is and what measurements are needed to determine next steps in treatment, which there's no reason that they would know that yet. So we got to disseminate this.
So we've been working on that through the American College of Radiology, because the big question is, when a radiologist is out of training, how do you get information to radiologists everywhere in the community? How can you let them know if they don't all come to this meeting? They don't go to whatever. They don't maybe read journals. I don't know. We're just busy these days. So super helpful to have this come up so we know what to read about. Like, I know, I better learn what ARIA is. It's we said, what is this one? The next one. So we're watching them carefully, and this is their next post-treatment scan. We're skipping the E because in the interest of time, we're just going straight to the H.
Yes. Okay.
So you want to say anything? You want me to say?
Well, I guess the question is, you guys see anything on there? This is our follow-up scan 1 month later. We had a sulcal effusion in that parietal occipital region. And I think say that.
That one resolved.
Yeah, right. And so that resolved is gone. And now we're looking at this GRE that is showing a little bit of superficial siderosis. I didn't see it initially, but I have been through the slides. So.
I've been through the slides. I know. So these are the kind of things that again, in the beginning, we would have thought, that doesn't matter. It's so subtle. What does it matter? But it does, right? It does, because it's indicated that something's happened. So if you see kind of that parietal occipital region right there along the surface, the brain surface along the cortex, you got that little, area of superficial siderosis. There's also a little kind of punctate thing that you see a little better, but I think that was there before in retrospect. We won't worry about that. That's not a new microhemorrhage. I'll just say that. I don't know if you can see in the light. We need dark to see these things. But so they do have now at least one. Next slide. And then also, actually, they have more superficial siderosis. They have that right temporal lobe as well. So now I'm going to call 3. My fellow called 3. I think he's right. Can we check with the report? I need my help to double check because I've got 80 more studies to do. Okay, so yes. So this is going to help us say 3, and it's going to give me this new one. So I could look down somewhere here for the grading system, but it's telling me it's severe.
Yes,
so I'm yes, I remember that.
The grading system is automated within the software. So that's kind of part of this on the report. And I actually didn't look at this. Interestingly, oh no, that's parietal occipital. Okay. So it's actually counting the one in the back as 2, and not the one not the signal in the temporal lobe, which is what I thought it was counting as 2. So this is actually really important because a second area of superficial siderosis is moderate, and 3 is severe, and so they don't go back on treatment, and they can go back on treatment, and it also is really challenging when we have just one cut like this to know for sure. So consistency is really important, which
Yeah.
comes with having a software program.
Feel the same way every time. It's radiologist won't. All right, next one, Lars. Okay, so that's, you can't read, that's too small, too many words, but that is based on the American Society of Neuroradiology template. So this is what comes out automatically, pre-populated, which everybody's so excited about. And then it has the grading at the end, just so you can double check everything. But this can either, it can either be a one template, but you can also, I think, put the macros into a PROS report, which is super important to some radiologists, but super nice feature that everybody, radiologists love this. I don't know about you.
Oh, yes, for clinic.
Okay. Okay.
So we stopped therapy and did not restart, as they had 3 areas of superficial siderosis, which is contraindicated actually to restart therapy. And that is not actually my patient. So I'm not sure how they're doing, but hopefully well. So basically what we're trying to highlight here is the importance of A, knowing that you're looking for ARIA on a scan, but B, counting accurately the amount, the importance of the consistency from scan to scan, especially within the person. And it actually guides us down what pathway we're going to take for patient management. I want to open the floor for questions, but there is a second case I could briefly talk about if there is interest.
I'm interested.
Okay. All right. I will discuss the second case. Okay. So so first I introduced as Dr. Lapins. I work at Northwestern. I was trained at and also work at the Meslem Center for Cognitive Neurology and Alzheimer's Disease. Dr. Marcel Meslem was the first person to describe primary progressive aphasia, which is what this case is going to talk about. It's a pretty rare diagnosis. It's a clinical diagnosis, so it shouldn't be made based on a read, but there can be supportive features on a scan that can be really helpful clinically to know about, so that we can know if we should be following them over time. So this is a 69-year-old woman who's having word-finding difficulties that have progressed over time and is starting to have some mild other symptoms of forgetfulness. But on her initial cognitive testing, we'll say all she had was an anomia, trouble coming up with words. We got an MRI scan and it looked like that. And it really didn't look, too atrophic. And there wasn't really focal findings, but using this program and taking a close look, even on the first scan, there's a little asymmetry going on between the hippocampi that are it's probably so subtle that you guys are like, that's normal. What are you talking about? And it can be normal. And if someone is having a progressive aphasia and has an asymmetrically smaller left hippocampus, that may be relevant and should be followed over time closely. And probably after that first scan, I would be getting an FDG PET scan based on that asymmetry and the patient's clinical findings. So this case is meant to highlight that even though something looks like it shouldn't be clinically significant and may not be, it will be. It may become significant, and that information earlier is helpful because they're not treatable later in the disease. We can only initiate anti-amyloid treatments early when they're mild in their disease course. We see similar things in frontotemporal lobar degenerative diseases. We have this conference that we do where I work, where we look at correlating clinical presentation and MRI findings and autopsy findings after they pass away. And what we tend to see, which surprises people, is some types of FTD do not have a lot of atrophy and can be read as normal throughout their whole disease with just minimal shrinkage over time of their frontal lobes. That looks maybe normal for age, but perhaps there's an asymmetry and it's more on the left side and the patient's having trouble getting words out. That is our language production center. So even the subclinical tiny findings can be really helpful to us nerds who like to look at patients like puzzles and help figure things out earlier when they can still understand.
So I just learned about this just now. So this is super helpful. I actually said we shouldn't include this case because I said any radiologist here who looks at this is going to say, not only is there no change, but it doesn't matter because there's not, I mean, this looks fine. It's normal. I mean, it looks better than a lot I see, whatever. But so that is super helpful to me because she just answered the question I think that I would have had if I was in the audience. You know, I would have said, no, that's silly that's different. But now I know why it's important. I didn't know that before just now. So thank you. This will help radiology. Yeah. I don't think many radios.
I don't know if I have more to say about it.
Keep going.
Yeah, I think that ultimately this picked up on that asymmetry and noticed that it was on the left side and in most people who are right-handed and most people in general. Language is lateralized to the left side, so that could correspond, I would say, supports a potential diagnosis of logopenic primary progressive aphasia. Do we know if it's due to Alzheimer's? I would say not yet. We need some biomarkers, but could be. And then they may be treatment eligible, so important. And they have a tiny microhemorrhage and some very mild white matter disease, which is not a contraindication to them starting treatment. And I do have So we see a lot of aphasic patients because I work at the Meslem Center. And so I do have some logopenic primary progressive aphasia patients on treatment. It's hard to monitor them because the screening test to determine if they're eligible is biased against them. It uses words to test memory, which isn't fair if you can't come up with words. So there will probably be some research coming out in the next few years about using these medications in atypical clinical presentations. That can be a language problem. That can be a visuospatial processing problem. It can be a behavioral problem even. So Alzheimer's disease actually can present any way it wants to. We like to say if you've met one person with Alzheimer's disease, you've met one person with Alzheimer's disease because they all have a really different course. It's really different one patient to the next.
Well, it's actually about one patient to the next. It'd be interesting now with this data to see, I mean, what kind of new, maybe neurodegenerative diseases might we find? Because you're just saying one patient with Alzheimer's is one patient, but maybe now we'll even see new patterns. And this actually, the quantitative, the volumes would actually help with that, right?
Yes. And we used to think we're just finding out more and more that clinically we're really not great at distinguishing who actually has what disease under the microscope. It didn't matter as much before when we didn't have treatments to stop the disease we're seeing under the microscope, but it does matter now. It's my train of thought. These, the DVAs, yes.
Oh yeah, DVA.
So,
vascular malformations.
Yes. Vascular malformations, which are incidentally seen all the time. Most are contraindications to starting this treatment, and getting a vessel study isn't something that's required prior to starting treatment. So it's something that hopefully they would know about or would be obvious on a regular MRI scan. I myself have a patient who has a tiny DVA. Sorry, not DVA. Sorry, I keep saying this. CCM, cavernoma. Okay. It's in her brainstem. They don't usually bleed. They're venous side, but there's not data yet. And about whether or not it's safe with these types of treatments. I kind of checked with both drug companies. And so we had this long conversation about, you are eligible, you're definitely eligible, question mark about this one thing. Some of my colleagues have given it to those patients, but because hers was in her brainstem, we talked about that if it bled, that would be quite bad. She would have many symptoms and could be debilitated for a long time, forever. And so she decided not to go on treatment and feels really good about that decision because of all of the unknowns. So this just kind of harps on the importance of reporting everything you're seeing on the scan, because anything might be relevant to the patient's safety. And if we knew about it ahead of time, that's bad.
Yeah, there's so many things that we take for granted. Like, I think everybody has a cavernous malformation, cavernoma, because we're a cavernoma center, but we also think they bleed every time. So I'm thinking that's super dangerous. And yeah, that's a good idea to watch for those. You said no vascular study is needed. So like a lot of people with the aneurysms probably wouldn't be seen. But maybe DVAs and cavernomas. That's something I'm going to go tell all my colleagues now. We need to, make sure, because we see it so often. We don't talk about DVAs anymore.
Right.
Even cavernomas, maybe if they're small, we don't.
And it might
but now we know why. We have
be
to.
relevant. We need the data, and we don't have it. And it's
changing.
Yeah. But they are in the current studies, so we will be getting the data shortly.
But having a way also to know these updates as things change.
Yes.
We don't even know. We're not even at the beginning yet for everybody. So as things change, we still need ways to figure out how to let everybody know.
Yeah.
Radiology wise. But so that's again super helpful. I've learned a lot. And I'm going to tell everybody I know all the stuff you taught me today.
There's even, a lot of centers are doing like conferences, like how they do tumor board conferences to talk about patient eligibility. We're trying to come up with something similar, and for community referrals to kind of determine eligibility in advance. So there's a lot of ways to go about this as a center.
Again, that's something. So we don't have that, and we never will, because we have so many other conferences. We have tumor, we have neurovascular, we have epilepsy, we have all these other ones. So we're never going to get an ARIA, even though we are an ARIA center. But but even more community. Nobody's having multidisciplinary conferences. So again, that's why all this, the work that's here is based on you, because I know these guys based all this stuff on the literature and created a lot of, a lot of this literature has been partner in the scientific studies that have defined all this stuff. So, so that is what I think everybody out there needs. And we're talking about reaching all the population, which is so overwhelmingly much, we know. Yeah. And 90% of those, however, are not maybe going to get treated at a big center that has the conferences, right? Yeah. That's going to be, so they need more help.
Yeah.
More help.
They need more help, standardization. I've talked to a general radiologist who said, I don't think your patients who are getting screened for ARIA can come to this location because I don't feel comfortable reading ARIA. So our patients have to drive downtown, and it's really inconvenient for patients who have mild dementia and maybe aren't driving. Home infusions, it's a problem, not covered by Medicare. There's just lots of limitations on this patient population. And so anything we can do to make this more accessible, because it is extremely prevalent. And now they're trying to look at asymptomatic people and seeing if pre-treating them before they have symptoms is going to help. So we're just going to be talking more about these medications and picking up this disease earlier and earlier.
I'm going to say, and where, for the radiologists who might be watching and learning about this, the places where we can get information, where can we get it? So I'd say ACR, ASNR, but also again here, because all the information is even included on this report. Yeah. That's a great starting place for any radiologist, to learn more about it. Again, if we have this report come up in our system, even if I didn't know about ARIA, if you're out in the community, whoever, now I'm going to look it up. I'm going to see why am I saying all this, maybe.
Yes.
Even if I don't, at least somebody, is saying it for me. But I think it's going to really be important to help all the people out there who don't benefit from the ivory tower.
Yes.
And,
and then the last thing I'm going to talk about is my snowbird patients. So we all know we can't see scans from different institutions or across state lines. Half of my patients who are potentially eligible aren't on treatment because I feel like I can't rely on some random person in another state reading the scan who I can't talk to and who I can't see the scan. And so the access to care is being impacted by comfort reading these scans and comfort with who's reading these scans. And so a software like this just seems so important to me clinically, for me to be able to give this medication to as many people as are eligible and interested in it.